getting good feedback from everybody that the audio video is clear. We're very happy about that. Just in case any center has any issue, make sure that you reach out to my colleague, Mr. Bhaskar. During the program, please do not call us, call me or Chandu or Dr. Roshan. We will not take your calls because we are with the faculty in the audio room, and we will not be able to receive calls. It will disrupt the flow of the presentation. Any questions, anything you have, please put it only on the digital CME group. It's my humble request to you. Avijit, okay? Ready? Just another 4 minutes, 3 minutes.
I'll just get my talk ready.
Yeah.
It's already sharing is on?
Yeah, sharing is on. Almost 150 centers. Chandu, what's the number? So doctors, ladies and gentlemen, we're just almost 3 minutes away from the start of the event. Faculty has just arrived. Dr. Ramana is getting prepared to deliver his talk. So I do hope that you're all well settled and the connections are robust, streaming well. To my esteemed colleagues from Heldium, I request you to please mute all your phones in the interest of the audience. In the interest of the audience, and let us not disturb the floor. Please take a piece of paper and be ready to collect questions. Take a snap and put it on the WhatsApp group. That's better. Make sure that the questions are legible. Please mention the name of the surgeon and the place and the hospital from which the questions are coming. So I will be very delighted to answer all the questions in the interest of time. So once again, thanks, ladies and gentlemen, for joining this program this afternoon. On behalf of Heldium, I'd like to welcome you all and also doctors from Europe, from Nepal, Bangladesh, Sri Lanka, Bhutan. Thanks a lot for joining the program. Kindly make this interactive. You can also put your questions on the chat window, which you can see on your screen. So we'll be taking all the questions and putting it to the faculty. So I think now we are at the start of the program. Let me take the privilege and honor of introducing the faculty. Somebody want to change the screen? So I'm very honored and delighted to introduce Dr. B. Ramana, a well-known and senior GI and bariatric surgeon from Kolkata, which is Eastern India. I think Dr. Ramana does not require an introduction, but I think I still should do it. At present, Dr. Ramana is a consultant surgeon at Apollo Hospital and Bellevue Clinic in Kolkata. He is also the current president of the Asia Pacific region of International Bariatric Club. So Dr. Ramana has vast experience in general GI, laparoscopic, hernia and bariatric surgery with world-class surgical skills. He's been a bariatric surgeon since 2004. He's handled several complicated procedures since 2006 and has an experience spanning more than 25,000 cases. So he's a pioneer of eTEP procedures in the Asia Pacific region and author in its first publication, the Surgical Endoscopy of 2017. He's published more than 20 research papers, and he's a faculty in more than 13 national and international conferences. He's extended his expertise in more than 12 organizational affiliations. So it's a pleasure and honor on behalf of Heldium, sir, to welcome you to this program. And the floor is yours. Please take over. And so we'd like to welcome Dr. Ramana.
Hello. Thank you. Thank you very much. So good afternoon to everybody across the world. So many of you are enthused and excited by the field of AWR surgery, as I am. And things have been evolving for a number of years, but a dramatic change has been when the procedure of posterior component separation, or TAR, came into being thanks to Yuri Novitsky, who published the procedure that he has helped develop. And of course, subsequently, many others have contributed to its evolution to its present day. So it is important for any surgeon doing AWR to have a very solid foundation of the topic of the procedure of TAR, transversus abdominis release. And I'll just take you through the steps, and we will delve deep into the technique and the pros and cons of it. So you'll have to be patient. If you don't have that patience, you don't really belong in AWR, because our procedures often need a lot of stamina and patience. Okay, let me start. Can I have my slide show present? What do you want? You want to escape? Yeah, exit. Okay. All right. There you go. Are we good? All right. So open TAR technique, tips and tricks, nuts and bolts. So these are my organizational affiliations: the International Hernia Collaboration, the AWR Surgeons Community, and the IBC are associations, as are my hospitals. At the outset, I would like to extend my heartfelt gratitude and thanks to many of the pioneers of the AWR world, and I will not belabor the point that Yuri Novitsky started it all, and people like Igor Belyansky, Eric Polai, Conrad, and of course, the redoubtable Mike Rosen have put their own wisdom and aspects into developing the procedure. I'm also grateful to my assistant, Dr. Ankit Mishra, who has toiled very laboriously to edit these videos and make them useful to you. And I hope you will enjoy those videos today. And Dr. Sudhir Kalan, Vivek Bindal, Mukund Khetan are all colleagues in Gangaram Hospital, and my colleague Pramod Shinde of the AWR Surgeons Community. They are all people that I work with, and I'm proud to call my brothers. So only one disclosure: I will be hopefully receiving speaking fees from Sutures India for this talk. All right, so when we talk about AWR, what do we mean? The basic concepts is that we close the midline linea alba. We do this closure with minimal tension. We place the mesh in the retromuscular space, and we put in a wide overlap of mesh according to the principle of STOPA, that is the GPRDS. And these are our broad principles, and these are based largely on experience, empiric evidence, as well as data which is accumulating over the last several decades. So let's go on to when we should do a TAR. You have a patient with a 4 centimeter umbilical defect. So are you going to plan a TAR? Let's see the kind of patient I'm talking about, just so that you don't use the knowledge of the operative technique and apply it to the wrong patient. So this is typically a patient with what we call a front butt, a patient who looks like the buttocks are in front, and this is a giant or at least a large hernia, a complex hernia, probably recurrent. You see that midline scar. A hernia hanging down like a big handbag, lateral hernia. A hernia that happens after left colon surgery and a stoma. It could happen after right colon surgery. It could happen with any stoma, but a hernia in relation to a stoma in relation to a bony prominence like the iliac crest, like the pubic bone, is a complex hernia. Often, the midline scar is also involved in this hernia, making it even more difficult to handle. This is the kind of patient who needs a TAR for an effective repair. A patient who has undergone multiple procedures, maybe cancer surgery, maybe urologic surgery with another complication which needed a laparotomy, and has multi-quadrant weaknesses, hernias in the umbilicus, in the upper abdomen, in the flank. How are you going to protect all these domains of the abdomen? The one operation is TAR. So this is such a versatile operation that you can use it even in giant scrotal hernias, because when there is a giant scrotal hernia and loss of domain, when you repose all the contents back into the abdomen, the intra-abdominal pressure may become so high that it causes abdominal compartment syndrome. So reducing the intra-abdominal pressure is a separate subject, but one of the things we would need to do is a transversus release after for this kind of operation. So before operation, whenever you're going to do a TAR, you should have a roadmap. You should know whether previous meshes were implanted or not. What is the status of the rectus abdominis? What is the status of the oblique muscles? What are the contents? Are there adhesions or not? Many other things. How would we know all this before operation? CT scan. That's one simple investigation, and AWR surgeons should be able to read CT scans with considerable competence. You also should realize that you can't just pick a patient off the clinic and admit to the hospital and do a TAR the next morning. These patients often need optimization. What are the most important things? I'm not going to bore you with details. The most important things. Does this patient need to lose weight? If the patient has a BMI of more than 35, you should think of this first. The higher the BMI, the greater the caution needed before you say, I'm going to operate. Second, diabetes control. If the HbA1c is 7.5, 8, 9, don't operate unless you are stuck in an emergency. That's a different story. But no planned operation, especially AWR operation, should be done if the A1C is not under control. Something like 7 should be a very good parameter to keep. Is your patient a smoker? If your patient's a smoker, you're going to have greater complications if he doesn't stop smoking. So at least a month of smoking is essential. Other things are important. I'm not going to go into details. Nutritional rehabilitation or prehabilitation is important, as is taking care of the bacteria in the nares, in the body parts of the patient, whether we can reduce mesh infections by preparing these patients in a special way or not. Those are, again, as I said, separate topics. Before you go into the operating room with the patient anesthetized, make sure, and I'm talking to those of you who do not work in ivory tower hospitals, which can compete with the best in the world. I'm talking about you who's working in a small town setup or a district hospital which has seen better days, that kind of setup. You ensure that you're properly equipped for the surgery. So make sure that you have a bear hugger if possible. A bear hugger is something that warms the patient, and a major open operation means that the patient's body cavity is exposed and the body becomes cold. So the fluids should be warm, the patient should be warm, because hypothermia is a genuine problem for the patient. You should have an indwelling catheter, and you should keep a DVT pump in use for all of these patients. Make sure these are long procedures. The patient should have the bony points padded up in order to avoid nerve compression. What are the sutures and other things related that you need? Take a 2O PDS, 3 OPDS for very thin peritoneal closures, or you want to close a bowel injury or a ceromuscular tear. Take 1 OPDS for thicker tissue like fascia. You want to close the linea alba, use 1 OPDS. Skin closure is fast and effective with skin staplers. And most people would put in suction drains after this operation. What kind of mesh do you need? The basic thing that you should ensure is that you have the largest sizes of mesh available. Across the United States, they have 50 or 46 sized meshes, 46 centimeters into 36 or 50 into 50. In Europe, they do, I know. Unfortunately, in India, we do not have these very big meshes which are suitable for the TAR procedure. So what we do is we take 2 30 into 30 sized meshes and we quilt them together in a home plate formation, and then we implant it. So the basic polypropylene mesh is what is the most popular mesh used for the TAR operation. Sometimes when you can't close the defect, when the patient is very obese, then it is probably a better idea to use a heavyweight synthetic mesh. You may also need a vicryl mesh to bridge a gap in the peritoneum. If you lose a lot of peritoneum from adhesions or from removing an intraperitoneal mesh, then you may not have enough peritoneum to close. So what do you do in that case? In that case, you use a vicryl mesh to bridge the gap of the peritoneum. Sometimes it's useful to have special meshes. Many people use coated meshes when they can't close the peritoneum. I will warn you here. It is one thing to use a specialized mesh like the tie mesh, which we are talking about today. It is one thing to use what is basically a special form of polypropylene mesh, but to use a coated mesh in the retromuscular space just because you can't close the peritoneum is generally associated with worse outcomes. So if you do a proper TAR, you should be able to close the peritoneum, and you should be able to get away using a relatively easily available and low-cost, simple macroporous polypropylene mesh. Can you use polyester? Yes, but polyester has been withdrawn for this operation in the US because of central mesh rupture. It's also good to have a pulse lavage irrigating device. It's disposable, and if you can keep it in your operating room, it's good. Otherwise, it's not really a big deal. It has been shown to reduce wound occurrences. Among the surgical instruments, these are very basic, but in many countries, basic instruments are of very low quality. And I haven't found too many hospitals where you get excellent general surgery instruments. So this is something which I am very particular about, that you should have scissors that are sharp, scissors that do not grasp the tissue but cut it. So bipolar cautery is definitely something I would want to keep. Keep a piece of cautery cleaner like a sandboard, and a malleable flat retractor, Richardson retractor, that is useful, as well as a large packing towel. A large packing towel to pack off the whole peritoneal cavity, you'll see it. And if you can use a headlamp, then it's good practice. I like to have a headlamp, but in a long procedure, I start getting a headache. So let's start with marking. So the patient's on the table, you have examined the patient, you know the problem, whether the patient has a lateral hernia or a midline hernia, upper abdominal hernia or a lower abdominal hernia, or multi-quadrant hernia. This patient that we are seeing has had a laparotomy and a flank incision for complicated GI surgeries, and the patient has a lateral hernia and a wide central midline scar with a very small defect in the midline. So this patient really doesn't have a midline problem per se, but rather has a flank or lateral muscle problem. So we are not going to need a bilateral open TAR. We will just need a unilateral open TAR, which is basically on the patient's right side. So the camera here is looking from the head end of the patient, and you're basically looking to the defect, which is on the right. So the incision technique. So you might be wondering, what is so big about incision technique? I'll just take a knife, I'll slash through the midline from top to bottom. Yes, you could. I used to do the same, but I've learned this from Eric Polai, where he uses only a small part of the abdomen, typically the non-violated virgin part of the abdomen, or the least risky part of the abdomen, to gain access. So once you gain safe access into the peritoneal cavity, you then lyse the bowel adhesions a little further down and then extend the incision to that part. So you go serially, stepwise, in order to avoid getting into a mess of adhesions and accidental enterotomy. So in these cases, redo cases, you may encounter mesh, you may encounter sutures, knots with granulomas, and sometimes even tiny old sterile pus pockets. So you can see here that we are holding up the edge of the anterior fascia, and we are now dissecting off the adhesions just below it. Now, I like to use sharp scissors, and I use it in a backhanded fashion, and it's very effective and elegant, but whatever is comfortable for you is okay. I would caution against excessive use of blunt dissection because you can tear bowel while doing so. So sharp is what I like, and I would say cold steel is pretty safe. You should cut what you can see and identify. So you can see here that we are going serially. When you see adhesions which are not bowel and they look vascular, you can use bipolar, you can coagulate it, and then divide it with scissors. So a lot of today's videos will be real world. They are not dolled up to make it look especially good. It's not something which I have created a surgical Photoshop on. This is as real as you see it. I've probably done this operation last week, and you can see pretty much every step of the problems that we encounter in patients like this. So adhesiolysis is an extremely critical part of the TAR operation. Here, I must say two things. One, all adhesions to the abdominal wall till the flanks have to be cleared. Top to bottom, side to side, all adhesions to the abdominal wall have to be cleared. Why? Because if the adhesions are still stuck to the sides of the abdominal wall, the mobility of the abdominal wall will be less. Your release will be less. You can't close big defects if you don't get adequate release. The second thing I would like to say is, don't go into the loops of bowel and the interloop adhesions. That's not much beneficial unless there is a specific history of obstruction that you need to rule out some other cause like a band or adhesions or something. So for me, the biggest goal of the TAR operation is not to put in the biggest mesh, not to close the defect very firmly, but to escape without injuring bowel. For me, that is number one. Once I do that, then I'm king. You extend and complete the incision safely. So that is the first initial part of your operation. Question often asked is, do I really need to go from xiphoid process till the pubic bone? What if I make my incision for a lower abdominal hernia only till above the umbilicus? Look, don't mistake the usual mesh overlap metrics, the measurements, with AWR like TAR. If you're thinking of 5 centimeters across, 5 centimeters above and down, you're not talking about AWR principles, TAR principles. Here, we are going to reinforce the visceral sac. We really don't care what the defect size is. We are only interested in the domain, in the entire area. Whatever is released has to be protected with mesh. So we really don't care if it's 5 centimeters overlap or 15 centimeters overlap. If the patient needs a TAR or the patient needs a Reeves Stoppa dissection, that retromuscular or extraperitoneal or pretransversalis plane is what is going to be the last resort for that patient's hernia repair. You're not going to revisit that plane. So if you leave that unprotected and the patient has a recurrence from there, then where do you go? Where do you put the mesh then? It's a difficult situation. So if you are going into that plane, if you are doing a TAR, then do it properly, reinforce that entire area with mesh, no short measures. However, if you think that you don't need to go all the way and you can comfortably protect the patient's damaged abdominal wall, go ahead, use your surgical judgment. I hope that answers a lot of questions. So once the adhesiolysis is done, we are now going to prepare for the retrorectus dissection. Now, obviously, now we have a full-blown laparotomy with open abdomen, and we need to protect the exposed bowel with a giant mop. Here, I'm using a green towel. The problem with using a green towel is that it's lighter, so it tends to roll. If you use a specially tailored mop, then it is heavier and stays better. It keeps the bowel down. Otherwise, the bowel tends to escape from the sides of a mop like this. But you have to take time to put this in all the way through, up and down, and ensure that the bowel doesn't escape. So if you see here on the side, the bowel is tending to escape, and we are pushing the mop from the roof down, from the ceiling down, till it lies on the edge of the paracolic gutters, so that the bowel will not come up while you're doing the TAR. So now hold the cut edges of the rectus sheath on one side. Now what you see is that this is the cut edge, this is the peritoneum, and we are marking the edge 5 millimeters or so away from this edge, the edge which is being held by the Alice clamps. So hold the full length of the rectus sheath with Alice clamps and mark with cautery around 4 or 5 millimeters away, and start using cautery and dividing the peritoneum. Now, if you notice carefully, you will see that we are dividing peritoneum, and just underneath the peritoneum, while you might be expecting the posterior rectus sheath, this is actually subperitoneal fat. So you can see that subperitoneal fat here. So this is a nuance which you need to be aware of, and you can now see the exposed fascia transversalis and posterior rectus sheath. So we are dividing with monopolar cautery, and the underlying rectus abdominis muscle is very clearly visible. Now, one technical point here is that where should you make the incision? Because the sac may mislead you, and once you divide it, you find that you've gone through and through. You have to feel for the rectus abdominis before you incise the peritoneum. I hope if there is a problem understanding this, we'll discuss this at the end. So we know for sure when we are dividing here that the rectus muscle is here. How do we know? Because we can palpate it, as simple as that. And you can see the twitching of that rectus abdominis, the vertical fibers are aligned. So you know that this is nothing other than rectus abdominis. So the incision on the posterior rectus sheath is now completed so that you have a medial posterior rectus flap here. Now we are extending the incision further up. You can see that. This is, how it is on fast forward. So don't think that I'm having a seizure and epileptic fit. So this is exposed posterior rectus sheath. And now we are doing the Reeves dissection. You can see a neurovascular bundle coming up. You don't want to be rough, have to be gentle. A caution, when it comes to giving traction with these Alice clamps, please be gentle and firm. Do not use excessive muscular strength. You can see another neurovascular bundle coming here, and I'm pointing it out. It's surrounded by fat, so just be careful not to injure it. This is one of the most important things that you should take away when you leave this session. Now, I'm just showing that when you get older, this kind of operation does tax your body. My hands are cramping. So I have a wrist problem, and wearing double gloves cramps my hand after a while. So coming back, this is the retrorectus dissection. Pick up the posterior rectus sheath and divide it on top of your finger. Take it bit by bit, steadily. Don't cut muscle unnecessarily. Don't cut away from your intended line of division, so that your operation starts and ends according to your precise calculation. Precision in surgery is very important, and I don't think we teach that part well enough to younger surgeons. So we're talking of the Reeves Stopa dissection, and I would caution you to do certain things when you're doing this retrorectus dissection. First thing is identify the neurovascular bundles, which I showed you. Divide the medial perforators. Now, what do I mean? There's a very common mistake. When you do the retrorectus dissection, you will see a vertically aligned blood vessel coming up. And you think, oh my God, the neurovascular bundle comes up much faster than I thought. It's much more medial than I thought. And you protect it and try to dissect just a little by its side, and then start dividing the posterior rectus sheath, thinking that you're going to do the top. The biggest mistake that you can make. That is a medial perforator. It goes up vertically. Divide it. That's not your problem. The neurovascular bundles come further laterally, and I'll show you how they look. So dissect carefully and fully. Incomplete dissection is not acceptable. The rectus abdominis and the epigastric vessels stay on the ceiling. Okay, so all these safety points don't mean much unless you can see what I'm saying. So look at this. This is how typically the retrorectus dissection looks. What is this? This is the rectus abdominis muscles. What is this? These are the neurovascular bundles. This is how they are aligned. You see, they are climbing along the sides of the wall. They are arching towards the ceiling. They're not going up vertically. They're arching up towards the ceiling, along the walls, like a creeper plant. So this is how you identify the neurovascular bundles. So you see that? This is how it would look, and how I showed you how they are aligned. This is how they are aligned. So we need to complete the Reeves Stopa dissection. At the top, what you see here in red is the upper part of the right posterior rectus sheath. This is the upper part of the left posterior rectus sheath. And this is the subxiphoid fat. Underneath this is the falciform ligament. The attachment of the falciform ligament to the posterior rectus sheath should remain intact, and this subxiphoid fat is very important to identify. And as you extend the dissection further into the subxiphoid space, you will see more of this fat. Below, you dissect till you reach the pubic arch. See that? That is your lower limit of dissection. On the side, this is the linea semilunaris with the arched neurovascular bundles. So this is your lateral limit of dissection. This is not TAR. This is Reeve-Stopa operation, which is the first thing you have to do. Once your Reeve-Stopa operation is complete, then you have to go start on the TAR. Before we start on the TAR, try to understand what is the anatomical basis of TAR and why people didn't realize that you could do a TAR and reinforce the entire abdominal wall. So if you look at this anatomy, this is the midline, this is the fascia transversalis peritoneum complex, this is the posterior rectus sheath, and here the transversus abdominis comes in and joins here medial to the linea semilunaris. You see, the internal oblique splits into an anterior lamella and a posterior lamella. The transversus abdominis joins the posterior lamella and goes further medially on the rectus muscle. So this is the linea semilunaris, and the transversus in old anatomy books ended here. But no, it further extends medially. This important point is what makes the TAR operation possible. Now, first thing is we divide close to the edge of the rectus sheath where we did the laparotomy. So we incised around 4-5 millimeters away from the wall, and now we've got this posterior rectus sheath and peritoneum and exposed rectus muscle. Then we dissect further laterally till we can see the neurovascular bundles. Now, remember, this neurovascular bundle is climbing up towards the ceiling, so don't go there, stay below. So divide the posterior lamella of the internal oblique first. I'll show you all of this, so don't worry if you don't understand it. So divide the posterior lamella of the internal oblique, and then what you see is the exposed bare transversus abdominis muscle. Then you divide the transversus abdominis muscle, and voila, what do you have? You have a plane which is just on top of the peritoneum. So this is a pre-peritoneal or pre-transversalis plane which can take you all the way to the psoas muscle. And then after you close the posterior sheath, you can reinforce that entire giant space with mesh. So let's start with the transversus abdominis division, the TAR operation. The division is the most important thing, right? So this is how it should look. Now, what does this mean? This means that there is a neurovascular bundle here. This is the transversus abdominis, and you are dividing the transversus abdominis medial to where you see the neurovascular bundle. So don't divide it here. You will divide this nerve, and you will cause atrophy of the rectus abdominis muscle. So this is where you start doing the TAR operation. So let's see how it looks when you start doing the TAR. Start from the top, just under the costal margin. Why? Because the transversus muscle is thickest and fleshiest and most easily identified. Hook it up with right angle clamps or mixture and start dividing with cautery. Expose that rectus sheath. Yes, that's right. There you go. So expose it medial to the neurovascular bundles. The upper part comes up relatively effortlessly. The muscle belly allows the instrument to go in, and you can divide that. So when you divide it, some more muscle fibers, you can see thin fibers may be present. Just pick them up, divide them. Now what you see, that white pearly layer, is the fascia transversalis. Very important concept. You've already got the posterior rectus sheath dissected out. Now you have the transversus abdominis on the posterior rectus sheath. Now you're dividing the transversus abdominis. So what you get underneath is the fascia transversalis. This is well developed in the upper part of the abdomen. So bit by bit, divide these muscle fibers. So note that we are consistently staying medial to the neurovascular bundles, but not so medial that we are missing the transversus muscle, because towards the midline, the transversus muscle becomes aponeurotic, becomes thin. So you don't want to go there. You want to stay where the muscle belly is fleshy and easily discernible. You can check that this is the fiber which I want to divide. So this is how you know that it's going well. You have this exposed fascia transversalis visible, you have a medially divided edge, you have a laterally divided edge here. Now, at a point, you see suddenly it isn't looking so rosy anymore. The muscle has become pale and aponeurotic. Okay. Now, this is where you can start making mistakes. Hold the lateral divided edge of the transversus with right angle clamp and find a plane underneath it, beneath it. You can use bipolar, you can use monopolar, you can use Kittner forceps or peanut, and you can use scissors, whatever you like. Now, this patient had an ileostomy and has adhesions there. So you can see that we have made a hole in the posterior rectus sheath peritoneum. You can see the towel underneath. This is why it's important to have a towel, and if it's a colored towel, you can see it better. So I detected the hole early, and I knew that I had to go one level up in order to avoid further opening up that peritoneal sac. Now, knowing this hasn't come in easy. It has taken a lot of time and effort and experience to get to this point where I can quickly detect something going wrong and correcting my way. So now you see I'm going under the transversus abdominis muscle, the divided lateral edge, and I'm finding that extraperitoneal space, the pretransversalis space as we call it. And I'll show you more about this. There's plenty there. You can see that the peritoneum is thin, there is some extraperitoneal fat, and go slow, divide it bit by bit, stay right under the muscle. So as you keep dividing these fibers, take your hand further inside and depress it so that you keep getting the tissues put on stretch and the right plane keeps opening itself up to you. As you do the TAR, you have to take care of the entire abdominal wall, right? The transversus stretches from above to below. So now you have to complete the cephalad dissection. And you have heard stories about how difficult the cephalad dissection is. And my experience is most surgeons do not do adequate cephalad dissection. Yes, most surgeons do not do adequate cephalad dissection. Why? Because it's kind of a weird anatomy. Surgeons are not used to seeing that anatomy and they're scared of the diaphragm. So today, after watching this video, you should be very clear in your mind as to that anatomy, and you should make it a point that your cephalad dissection in TAR is world class. So this is cephalad dissection, and we are doing the TAR and we are creating space under the transversus abdominis, all right? Now the transversus abdominis, as you can see, has horizontally aligned fibers. We know that, right? Now, once you are in the right plane, you have to go underneath the costal margin. So feel the costal margin. So what you see here is the costal arch. So you can't go above the costal arch. That is the wrong plane. Go under the costal arch. And you will see now vertically aligned fibers, those belong to the diaphragm. So you can now take your monopolar or bipolar or scissors or peanut forceps, whatever it is, go slowly, stay in that perfect plane. And you can see that the cameraman is having a hard time trying to catch those fibers past my head. But when he can do that, what a joy it is to see those beautiful fibers and get on that perfect preperitoneal or extraperitoneal plane. So now what we have done is dissected off the peritoneum from the diaphragm. So the diaphragm is now part of my ceiling. Yes, past that is the diaphragm, and underneath is where I'm going. So I can go all the way till I reach the central tendon of the diaphragm. So where the peritoneum gets thinned out, I prefer to use sharp scissors and tease off those fibers bit by bit. You can see the color of the towel underneath that thin peritoneum. So don't be in a hurry and don't use your hands to tear these tissues. These are rookie mistakes. I've made them. I don't want you to make the same mistakes that I have. Okay? So use cautery or peanut or scissors. Sharper, the better. Now, I told you that I'm not going to dress up the procedure, the parts of the procedure. I'm going to show it to you rough and dirty. And often these are complex cases which have been operated multiple times. Doesn't get pretty, doesn't stay pretty all the time. So I'm going to take you through some of the difficulties which you may encounter. I show you a clean TAR, beautiful TAR, spotless. And then when you go to do it, you pick the wrong case and that case is a mess. And then you kind of get frustrated and say that, oh my God, this is something completely different. What did I do wrong? All you did wrong was you did not see more. You did not know more about the variations in the challenges which a TAR surgeon is bound to face. So check out some of this. You need to be patient, but you need to be geared and interested in this as well. So we are doing a case with a lateral hernia. This is the transversus divided edge. We are picking that up with a clamp and dissecting underneath with a peanut. All right. This is a standard part of the operation. Now, this patient has had multiple laparotomies and peritonitis. And he's had an ileostomy. So the planes are going to be difficult. I know for a fact, because of the history and because of the CT scan that I have checked, that this case is going to be difficult on the right side of the patient. Okay, the defect is on the right side, and the previous surgeries have been on the right side. Ileostomy has been on the right side. So I know that there's going to be a lot of messed up planes here. Now you can see the fascia transversalis being exposed under the transversus, and below is the peritoneum. You can see that. Now I'm going to divide that fascia transversalis. Now the best thing to do is stay right under that transversus muscle. So if you stay under that transversus muscle, what you will do is you will keep a buttress of fascia transversalis on that thin peritoneum. So this prevents you from opening up more and more of that peritoneum. It's very frustrating to have large tears of the peritoneum and have to close all of them at the end. So now we are doing the TAR. We are continuing downwards, and you can already see that the way we did it when we started off from the costal margin, now it's different. It's sticky. It's more difficult. We are going slower, bit by bit. Now, when you pick up the muscle like this, don't use the diathermy on the tip of that instrument because you might cut the peritoneum on the tip. So just cut on what you can see, which could be just on the sides of the tip. You can now see the peritoneum, the stuck muscle, and there is no plane over there. This is a plane which you have to create now. And if you are true to the planes, then ultimately the plane will yield to you. So you can see that the tip should not be divided because you might be pulling up the peritoneum when you're doing that. Okay, this is fast forwarded, so it's not as fast as it looks, but the idea is knowing where to divide. So take it bit by bit. This is not for the man or woman in a hurry. If you're getting married today, don't do a TAR. Do it after you come back from your honeymoon. All right, so you can see we are holding the divided edge of the transversus, and on my left hand, that's the peritoneum with the fascia transversalis, and I'm sweeping right under the transversus because I want to keep that fascia transversalis towards the peritoneum. As you go down, it is thinner and thinner. Suddenly, because of the previous ileostomy, you can't really get a plane there. What do you do then? You have to double down, go slow. Any movement in a hurry will not be tolerated well. It will lead to more tears in the peritoneum. It will lead you to go into the wrong plane. So you can see that peritoneum is already pretty thin. So you don't want to tear it because that will suddenly become very big. So going very slow, hold the divided edge of the transversus and try to find the pre-transversalis plane. So the planes in transversus abdominis division are very important. This is a small clip which shows you very nicely in open surgery the different planes that are involved. When you are actually dividing this muscle, what you think is the transversus abdominis, what are you actually dividing? This part of the video will show you. The first thing you divide is the posterior lamella of the internal oblique. There you go. That's the posterior lamella of the internal oblique. You divide that, and underneath you see the fascia, the transversus abdominis muscle. It is aponeurotic here, so you won't get thick red muscles like you get under the costal arch. Here you get thin white aponeurotic fibers, some pale muscle. That's on a good day. And underneath it is the fascia transversalis and the peritoneum. So once more, this is another chance for us to underline the previous lesson is stay pre-transversalis as much as possible in order to avoid tearing up that peritoneum. You see that plane? That is the best possible plane to possess. And once you possess that plane, do not let go. You see that bare muscle? That is what you want to see every time. The bare transversus abdominis should be visible. Now look at that. Every part of it is like a disputed territory between two unfriendly countries. You have to fight for every inch of that territory. You lose your attention a little bit, it slips out. So that is because it's sticky plane. And sometimes when you're dealing with these sticky planes, the pathological anatomy leads you to the different plane. And it needs training, knowledge of anatomy, and experience to realize that you're getting lost and to come back to safe land. Watch. So this is again lateral dissection, transversus abdominis release. You can see the peritoneum here, and there is a hole in the peritoneum because there was a previous stoma here, so it's bound to happen. Not a big deal. This is the rectus abdominis muscle. This is the divided transversus abdominis, and underneath it is our preperitoneal plane. You can see that yellow fat. That's a joy. You want to see that yellow fat because it tells you that you are reaching the land of freedom. That is where your space is going to extend all the way past the kidneys into the psoas. Now, here, where we made the buttonhole, we are coming back into the pretransversus plane, pretransversalis plane. See that? My finger is here. I'm dividing it right close to the muscle, and there you go. That's the fat. That's the muscle, transversus muscle. And we are now slowly finding our extraperitoneal plane. So you can use a sponge on holder. You can do this with diathermy. You can use scissors. You can use a peanut forceps. You can roll them up slowly. But if you do it roughly, you will have small vessels tearing and causing an ugly ooze. So if you have ooze, you can use a mop there, pack it, and do something else and come back and remove that pack later on. Check for hemostasis, of course. So you see that in the extraperitoneal space under the lateral flank muscles, you can go as far as the psoas major. And at this point, you will see all the muscles that you read about in inguinal hernia surgery anatomy. So like the iliohypogastric, the ilioinguinal, and all that. Now, because these are very deep, our external camera is not able to show it at least today. Leave something for later, right? So we are now completing the lowermost part of the transversus release. And what is that? That is division of the arcuate line. Once the arcuate line is divided, you will once more see the yellow fat of the space of Retzius and the space of Bogros laterally. Because that is the lower extent of the dissection, right? The pubic arch and the spaces above it. So the space of Retzius in the midline and the space of Bogros laterally. So there in the females, I would dissect out the round ligament and divide it. In the males, I wouldn't do a vasectomy unless I'm paid very highly for it. So this is an example of reclaiming your plane. You have to own that plane, and your owning it means you have to have knowledge of your territory, your terrain. So you have to be solid in your anatomical knowledge, especially in pathological states. So what are the endpoints of dissection? We just showed you laterally that you see that beautiful yellow fat and you know that this is the land of freedom. Go further laterally till you reach the psoas. Okay, so reaching the edge of the psoas is your lateral limit of dissection. Below, the pubic arch and the space of Retzius. Above, this is the diaphragm, which we demonstrated rather well, I think, just a few minutes back. And how wide is our space? Now see this, where you can actually see the actual mesh being stretched out, and it is showing us the extents laterally, at least the anterior axillary line. Cephalad, you go around 5 centimeters in the retrosternal area. You go underneath the sternum. You go beneath that xiphoid. You know, you dissected out till the central tendon of diaphragm. So that upper edge of mesh goes there, and the lower edge of the mesh goes into the pubic arch, okay, into the space of Retzius. So your entire visceral sac is now protected by a giant prosthesis like Stopa set. So midline hernia, subxiphoid hernia, suprapubic hernia, linea semilunaris hernia, flank hernia, any hernia can be protected. All these hernias together can be protected if you do an operation of this stature and quality. What happens to the hernia sac? You have a big hernia. What do you do with that sac? Here is an example, and I think it's a nice example of what to do. The rookie thing, which is to excise it, one problem taken care of. So let's move on to the next part of the operation. I've removed the sac because that is one thing that you think you should do. Rookie mistake again. Don't remove the sac. Keep the sac for later till you know that you have closed your peritoneal cavity completely, safely, and without tension. Don't remove the sac. Now watch. This is a large flank hernia, and we are taking pains after doing the TAR. We are taking pains to dissect off the flabby scar tissue around the sac. And now just watch this, why this is useful. As I said, I'm not cutting short any of this. In conferences, we get 15 minutes to talk of technique or a specific subject. It's not enough to give you a solid idea of the real life problems when you're dealing with complicated procedures like these. Now watch. Now we've taken that sac, we've disconnected it from its lateral scar. We're just putting in that mop for hemostasis purpose. We're just checking. That's the lateral flank muscles after the tar. See that? You can see some of the nerves there. Now, this is the sac. Now watch what we do to it. Saving this much sac took maybe 10 to 15 minutes of extra dissection, but it gives me immense pleasure to close the peritoneal cavity without any tension, because this entire flap is, you see that? That entire flap comes on top of the organs, and we can close that without tension. So we can fish out the sac by putting our hands into the defect and pulling it inside the abdominal cavity till you have a flap like the plastic surgeons do, and you can just throw it on top of the organs and then suture the edges. So this is an example of a case. This is a different case, okay? This is an example of a case where there was loss of domain. I did the tar and a huge mesh has been placed. I kept one part of the sac with me. Now, in order to close that linea alba, I would need to test whether the patient would be able to tolerate the raise in intra-abdominal pressure. In this case, the patient could not tolerate it. So what I did was I used this peritoneal flap and bridged the edges of the fascia, covering the mesh from the skin. So this is a way in which you can use that peritoneal flap, the sac. Now this is closure of the peritoneum using 2O PDS. If you want to use Vicryl, be my guest. If you have money, you can use barb sutures. So whatever it is, just close it carefully. Don't take bites through bowel, because as you get tired, you may make mistakes. You need to stay vigilant till the very end. So you see that each bite is measured, and it should not be too thin because it can cut out. And if it cuts out, the bowel can come out and get stuck to the mesh that you will place on top of this. So this is one of the possible advantages of putting in a tie mesh in this kind of scenario. In case bowel pops out of the stitch, it's still a mesh that doesn't encourage adhesions. So this is, of course, completely conjecture. There is no science on what I'm saying at this point. So I'll just fast forward a little bit here. You can see that that peritoneal flap is now coming. Okay. Measure the space that you have created. Now it's a huge space. Now this is going up into the retrosternal part. You can see that around 42 centimeters, because this is a 15 centimeter scale. So 15, 15, 30, and then 7, 42 centimeters. And this is a unilateral tar. So this is 15 centimeters and then another 7. So 22 centimeters wide and 42 centimeters long. We don't have a mesh of that size. So in some cases, as I said before, you don't have enough peritoneum to close, so you can bridge it with a Vicryl mesh. Okay? If you use a Vicryl mesh, it's not magic. Remember that bowel adhesions are more to Vicryl. You see the exposed transversus plane, so you can inject sensorcaine or whatever the Americans use, Exparel, and you block for postoperative pain relief. If you have gunk, bad scarry tissue, flabby tissue, necrosed tissue, granulomas, old sutures, bits of mesh, remove all of them and keep a clean ab wall. Take your time doing so. Now, what kind of mesh should you use? And this is a video of tie mesh being implanted in this particular case. I had made arrangements for it because of the fact that this patient had a bad GI surgery history, disasters and lots of adhesions. So I just wanted it to be safe in hand. We didn't have any enterotomies. So I'm using a 30 into 30 mesh in diamond configuration. Now, remember, this is a unilateral TAR. This is not a bilateral TAR. If it were a bilateral TAR, this would be too small. So a 30 size square, 30 centimeter size square, if you turn it till it becomes a diamond shape, that diameter is 42 centimeters. So do the math, I've done it. 42 centimeters is my xiphopubic distance, or rather the extent of my TAR coverage is 42 centimeters, and I'm using that mesh in the diamond configuration because I have that measurement sorted out. You saw that measurement being done. And laterally as well, it is going up to the anterior axillary line on the divided TAR side. On the patient's left, where we did only a reef stopper dissection, the mesh needs to extend only till the linea semilunaris. So you can see that the mesh is being placed and care is being taken to ensure that it stays flat without undue wrinkling or crinkling or folding. It is standard teaching to use cephalocaudal fixation of the mesh to the bony prominence or the musculofacial tissues. Here you can see a stitch being taken to the ligament of Cooper. So increasingly, the approach is now to avoid excessive fixation. So probably if you are starting off, then I would say just take 2 stitches to the Cooper on either side, take it equidistant and go through the mesh at the exact same distance from the midline, and take 1 or 2 stitches on the upper part. Laterally, don't bother fixing it because that lateral mesh is going to stay flat and it's not going to move anywhere. So this is as far as fixation is concerned. I'm a fan of no or minimal fixation. If you don't close the anterior fascia, if you're bridging it, then you should fix it. You should also use a heavyweight mesh if you cannot close the anterior fascia. I think most people who know me know that I don't like to drain, but open TAR is a place where I'm not too critical if you drain. Leave a drain for 7 days at the most, doesn't do much harm. And then you close the linea alba. Now you can close the linea alba in a running 1/0 PDS suture, but you can also use figure of 8 interrupted sutures and tie all of them together from top to bottom, because the maximum tension you expect is in the center. So bring the upper and lower part closer together, and then you tie them all sequentially one by one. So this is just to show you how big these sutures are taken from the edge. I don't take them the way the Israelson technique recommends, that you take 5 millimeters from the edge and 5 millimeters from the adjacent bite. But these are a little bigger, a little wider. And my idea is to bring them close without fear of either strangulating the tissue or having the tissue cut through and the suture failing in its job. So I'm just taking this through further down, more and more bites. And we are starting from below. More bites. Yeah, and now we are beginning to finish tying off. Now, usually senior surgeons leave this job to their residents and fellows, and I'm no different, but I make sure that whoever is assisting me knows what I expect him or her to do. So this is the end of this operation, where you can see that we have excised the lateral scar, and this is the midline scar. Skin is closed with staples. Now, in the case which I showed you, there is a lateral defect through the linea semilunaris. This is one of the most difficult defects to handle. This is the lateral defect here. So this is the big hole. This is lateral to the rectus abdominis. And we can't leave this open we'll have to close the defect using interrupted sutures once more. So I'm using interrupted 1/0 PDS sutures, and these are all flabby muscles which we are approximating close together. So many of you have asked questions in the past about how to handle linea semilunaris blowouts. So this is an example of that. From inside, you close the defect, and then you have a more or less reconstituted lateral abdominal wall there. So I'm just fast forwarding this part. But really, I should make you suffer and watch this, just like I suffer every stitch that I inflict on the patient. So once you close, that's how it looks. See that? That's right. So now your anterolateral abdominal wall is intact and you can place the mesh. So skin closure. We're coming towards the end of what is already an hour-long talk. Top mistakes in TAR. Igor Belyansky, a dear friend and surgical genius. He says, incomplete dissection, retrorectus dissection. I told you, don't do it. Dissect till you can see the linea semilunaris, the neurovascular bundles. Don't damage them. Putting a small mesh. All my Indian surgeon friends, stop putting in those single small pieces of mesh. You're doing no favors to yourself. Those patients are going to come back and haunt you. Pseudo-TAR. Pseudo-TAR is a topic which we have covered before and we will cover in greater depth in the coming months ahead. A very important subject where the surgeon writes in his op notes that he has done a TAR and the patient comes back with a recurrence, and you now have a difficult job because once a TAR is done, what are you going to do now? Because that plane is gone forever. So it often turns out that the surgeon actually never reached the TAR plane and never actually did a TAR. He did what is called a pseudo-TAR. He divided the internal oblique, he divided the external oblique, God knows. But bad things can happen in this operation TAR. We're going to talk a lot more about all this fascinating stuff from the leading experts of the world. Next year, May end, 2020 in Mumbai, Maximum City. We will have the best of the best in the world to teach you and train you open endoscopic AWR and stuff which you have every intent of learning but don't know how. Thank you very much for being patient enough to listen. And I'm all yours for the questions.
Thank you, Dr. Ramana, for the wonderful talk about TAR. Now we are open for questions across, and we hope that it becomes a very interactive session. We have the first question from Dr. C.L. Gurjar in Indore. What should be the ideal size to go for the TAR procedure? So,
size of defect?
Yes. Defect.
All right. So ideal size for a TAR procedure could be as low as 8 centimeters if the patient is very muscular, male, or obese. For an obese patient, an 8 centimeter defect is pretty big. It's difficult to close. So you would need a component separation for that patient. For most other patients, 10 centimeters and above is the real size where you are in TAR territory. Under 10 centimeters, you may end up doing just a Reeve stopa and getting away. Now here it is important or useful to learn about the Carbonell equation. Now what is the Carbonell equation? The Carbonell equation says that take the size of the defect, take the width of the rectus. So there are 2 recti. So if the size of the rectus added together is more than twice the size of the defect, then you don't need a TAR. Just a Reeve stopa operation is good enough. This is the Carbonell equation. You can go ahead and read up about it, or we can discuss it in our AWR Surgeons Facebook group. And of course, we have so many other opportunities to meet and discuss. Hope that answers the question. So these procedures are not easily understood when being done open. So I would also recommend that you watch the same operation being done by eTEP or by robotic access. It gives you a much better idea about anatomy, because not everyone is going to be able to show you with this kind of clarity. I was fortunate that I had very good quality in terms of camera images and managed to edit out those parts for you.
Some questions are still coming.
Right.
Typing. So
yeah. So
you may want to just
lots of questions coming up. And one of the most important things that I see is people either don't give traction or they give excessive traction. Now, when you don't give traction, you don't get into the right plane. But when you give strong traction, and when you're dividing the transversus close to the linea semilunaris, what happens is when you're pulling hard, you're pulling not just the transversus, but the posterior sheath, you're also pulling the linea semilunaris. And you know that the linea semilunaris is formed by the internal oblique, posterior lamella, and anterior lamella split like this, and the external oblique. So when you pull the posterior sheath hard, you can even pull that external oblique into your retrorectus space where you think is the posterior sheath, and you cut on that, you actually divide not only the posterior rectus sheath, you're dividing the external oblique, internal oblique, and transversus. It's a disaster. It's a linea semilunaris blowout, and that is why I would say be gentle, be patient, and know what you're doing. Every fiber should belong to one house. This is posterior sheath. This is peritoneum. This is fascia transversalis. You must know what you're cutting. That would be a very good way of reducing your chances of making a surgical mistake.
There's another question, Dr. Fahid from St. Mary's Hospital, Thodapuza, Kerala. I lost a bit on the incisional part. What would be the skin incision be for the lateral hernia?
All right. So a lateral hernia, you can approach it either through the same incision, in which case you dissect down, do the adhesiolysis, go into that retromuscular space. If it's a big hernia, or if it is associated with a midline component, then you would need to give adequate medial coverage. How will you do that? You have to come towards the midline. Now, when you are in the extraperitoneal space and dissecting medially, how will you reach towards the midline? You're in the retromuscular space. So that is when you have to do a procedure known as reverse star. So you have to divide the transversus from the opposite direction and then enter into the retrorectus space. It's nothing I would recommend anyone to do. It's the highest level of AWR skill. Please don't bother. I would say if you have a very large lateral hernia or a lateral hernia with a midline component, go straight midline. Go do the TAR the way you know how to do it. Then proceed laterally. Finish that job. I've shown you lateral hernias today several times. You can revise that scar, or if there is excessive skin, you can excise that skin laterally. So you have basically a T-shaped incision. Now, what I said initially when starting off with the incision is that you can incise from top to bottom and go deeper and deeper. I nowadays follow what Eric Polai does, is make a limited short incision at the site least likely to give you problems, say the subxiphoid part. The upper abdominal part, I make a small incision, deepen, go into the peritoneal cavity safely, then dissect the adhesions little by little till I get another little space to incise the linea alba and get in again. So going that way stepwise is a very safe though you may argue it's a slow way of going about it. Slow is good.
So you did mention about all the fixation points, but there's a request that if you can repeat that again and explain about all the fixation points.
Okay. So don't get fixated on fixation. The most important thing is safe adhesiolysis, perfect planes, possessing all the planes, giving the full coverage above, below, and to the sides. When you do that, you place the mesh from one anterior axillary line to the other, or from one psoas to the other, from the retrosternal area, all the way up to the diaphragm, down to the pubic arch. That mesh may not need fixation. It is prudent to say that you can fix two parts to the ligament of Cooper on either side of the midline. Make sure that if your bite on the Cooper is, say, 3 centimeters from the midline on the right, 3 centimeters from the midline on the left, then it should also be on the corresponding side on the mesh, 3 centimeters away, otherwise you're going to crumple that mesh. Above, you don't need to do too many more. You can just take one percutaneous stitch to the xiphoid. Laterally, you can take full thickness percutaneous sutures, 2 on each side. I think there are too many. You just can fix to the Cooper and maybe to the upper part.
There's a question from Dr. Shashidhar Reddy, KLE Hospital, Belgaum, Karnataka. If while dissecting bowel, bowel gets injured, so can we again put the mesh? Can we put the mesh?
Depends. If it's colon, I would say better not to. Even probably distal ileum. If it's jejunum and there is not enough soiling, I may do it. However, so far, every time I've opened bowel, I have not done it. I have just completed the adhesiolysis and I have gone out, told the patient's family that I've opened the bowel. So I did not want to take the chance of, if I've opened bowel, chances are it's a pretty messy abdomen. And if I have messed around inside the abdominal cavity with those adhesions and I have created damage, now I have a significant bigger job to complete after this, which is the TAR. So I feel that myself, I would choose to retreat for that day. I'll wait for the bowel to heal, come back 5 to 7 days, and then do the rest of the operation. So that is me. There is evidence that you can do a mesh repair in contaminated situations. You will have a higher incidence of wound occurrences and wound infections. But yes, you could do it. I personally would want you to do what is the safest thing that you would do for your own relative.
Sir, you have to be a bit short. There are too many questions. That is why. So we have to meet a lot of their
All right, sure.
Sorry.
There's a question from Dr. Saurabh Sharma, Fortis Mohali. What is the incidence of mesh infection, overall complication rate in this surgery?
Depends on who you are talking about. I would say that around 10 to 17% would be the range of wound infections, much lower than what you would have in anterior component separation, but much more than what we see in eTEP access or minimally invasive procedures. Recurrence rates, I would say, would be 3 to 4%. And probably in the coming years, we will see that in the high volume centers, at least the recurrence rates are bound to go down.
Dr. Santosh from Gaya, Bihar, which is the ideal suture for fixing the mesh?
Previously, we all used to use polypropylene mesh sutures, but nowadays the trend is to go with the delayed absorbable PDS sutures.
Dr. Mayank Mishra from AIMS Raipur, what is the advantage over Ramirez?
The biggest advantage is that the TAR operation is versatile. You can use it for any hernia which is troublesome. The Ramirez operation has a very high incidence, 40% and above, of flap necrosis and wound infections and all that. it cannot be done when there is a lateral hernia, post-appendectomy hernia, parastomal hernia, not suitable for all those cases. And the recurrence rates are much higher after this operation.
There's a question from SCB Medical College, Cuttack, Odisha. What if there happens to be a multiple defects in the fascia transversus while dissection? So a lot of openings are there.
In the peritoneum, you mean?
Fascia transversus.
Fascia transversalis, you're dissecting off the fascia transversalis, you're going to reinforce it with mesh. Nobody checks on defects in the fascia transversalis. We talk about defects in the peritoneum, and those have to be meticulously closed. Sometimes you can use omental buttress.
Doctor,
You can slightly elaborate, sir. It's not,
No, it's fine. I think they will understand.
Dr. Viral Shah from Sola Civil Hospital, Ahmedabad. After closure of the anterior sheath, if you find increased intraperitoneal pressure is there, and if there is hypotension, what will you do?
So, this is a very interesting question. Obviously, you understand the subject.
please repeat the questions.
So, the question is that you've done a TAR and now you are closing the anterior rectus sheath, the linea alba, and the patient's blood pressure is dropping. You're seeing the anesthetist running here and there. You see that the airway pressures have gone up. So now what do? The anesthetist may not know, may not tell you that there is a problem, but you should know. So the best way to handle this is to prevent this from happening. So what would I do is, when I start doing the operation, I ask them what the peak airway pressure is or the play-to pressure is. So note that at the end of the operation, before you suture the linea alba, hold the edges of the linea alba with clamps and pull them across the midline in opposite directions, mimicking an abdominal closure. So when you do that, ask the anesthetist what is the BP, what is the airway pressure, and how much it has changed. A delta pressure of under 6, I think, is okay. Anything above 6 is worrisome. So you should not close that midline. You can bridge it. So you should, that is how that peritoneal flap comes into use from the hernia sac. Then you can bridge that gap. Don't close it. Or there's alternatively, if you are a high-end center, you can handle all this high-end stuff. Keep the patient ventilated. Keep the patient supported. Patient will come out if it's not, you're not creating abdominal compartments.
There's a second question from Thoda Puja, Kerala. This is from Dr. Sujeev Pratap, Holy Family. Do you always remove a previous dual mesh if present before TAR?
Usually, if it's a dual mesh, like a Gore-Tex dual mesh, yes. But if you're just talking of a composite mesh, I may not remove it in certain situations, and I would remove it in certain other situations. The advantage of removing it is that you don't have to fear any aftermath of the previous mesh, like an infection in that previously placed mesh is going to be on you. But if you remove it, it's more work. You will lose more tissue. The headache is more to close it. But if necessary, you have to do it. I tend to bring down a coated mesh with the peritoneum and posterior rectus sheath and stay above it.
There's a question from Dr. Soumya Ranjan Rana, SCB Cuttack. What is the significance of cephalad dissection?
You know, very, very, very good question. The better you are at cephalad dissection, the better you are as a TAR surgeon. This is my experience. If you have a big ventral hernia to close and you feel that it is not closing well, I can tell you that you have not dissected the upper part well. If you dissect right up to the central dome of diaphragm, central tendon of diaphragm, then all your tightness issues will be at the least.
There's a question from Dr. Iham Arora. What is your take on the bottom-up TAR? Where do you employ this?
The bottom-up TAR is something I use when I'm doing the eTEP access. Not every time though. I typically handle the infraumbilical or umbilical hernias. When I do need to do a release, I start from below up. I really don't start from the top unless it's an M2 hernia as well. And some people like Miguel Garcia Urenia of Madrid, they electively do the bottoms up TAR, and they have a Madrid modification where they divide the aponeurosis more than the muscle. So the bottoms up may be a more convenient approach if you know what you're doing. If you're trained in doing the bottoms up TAR, go ahead and do it that way. Otherwise, most people will learn the TAR better the conventional way from the costal margin downwards for obvious reasons, as I said.
There's a question from Dr. Binay Thakur. If there is a big sac in the midline, where do you incise the peritoneum?
So, yeah, the question is, there is a big sac. What do you do with that sac? We've already dealt with it. You keep the sac attached to the sides and decide what to do with that sac at the end of it. So you can open on one side and make it a big flap connected to one side, or go through the middle and keep two flaps. Either ways, I don't think it really matters.
There's a question from Dr. Vinay Bhatt, Aster CMI, Bangalore. Do you prefer tie mesh versus dual mesh?
Dual mesh, again, that terminology seems to be a little suspect to me. What are you talking about? A PTFE mesh or a polypropylene mesh with a PTFE coating on one side? Because that is how I always known a dual mesh to be. It used to be a brand name, you know, Gore-Tex dual mesh is a brand name. But I think it may be loosely termed composite mesh. I don't have a dog in the fight, literally speaking. So I wouldn't say that definitively one is superior to the other. I like the feel, the handling of the tie mesh. And I like the fact that it is potentially versatile to be used intraperitoneally as well as extraperitoneally. That for me is, it gives me a very good feel. Whereas a coated mesh should not be used in the extramuscular, in the retromuscular space, ideally.
Dr. K. Gedam, Professor and Head of Unit, MGM Medical College and Hospital, Navi Mumbai, has a question. Do we need to irrigate the mesh after placement?
The incidence of surgical site infections has been documented to be less if you use pulse lavage with antibiotics, and otherwise don't use it. But there is evidence.
Dr. Srikant Patro from SCB Cuttack, how to deal with prolonged seroma discharge following a bilateral TAR, if there is a bilateral TAR?
Very unusual. Very unusual to have a prolonged seroma sustaining itself after TAR. If it is something like a chronic capsule which is formed around it, then you would need to go in and excise it. It's not going to heal with just aspiration, if you're talking about a prolonged seroma.
Dr. Siv Kumar from Apollo Hospital, Vellore, Tamil Nadu is asking, is there a structured AWR training programs in our country? Is there a calendar around it?
We're doing this all around the year, all around the country. Where have you been? You should know what we are doing. We'll be delighted to have you in our courses. We are doing courses right across the country, and we will be, you name it, live surgery, cadaveric, animal labs, didactics, everything is available, and we'll be doing it on and on. Don't worry. If you are part of our Facebook group, you'll know everything.
Dr. D.K. Sao from Bilaspur, he is asking, what are the disadvantages of polypropylene mesh in open repair of abdominal TAR?
I honestly don't think there is much to criticize about polypropylene mesh. If you don't use a microporous mesh, I think it's a very safe mesh to use. It tolerates infection to a fair extent, more than you think. So I would say really nothing bad about polypropylene mesh. It's cheap, it's easily available, it's great.
Dr. Alok Abhishek at Anupma Hospital, Patna is asking, what is the secure rate as compared to conventional techniques of the TAR?
What is the what?
What is maybe the complication rate of the conventional technique vis-a-vis TAR technique?
No, I think cure rate is what is
secure.
Secure rate.
I don't know what secure.
Maybe the
Cure
complication
rate.
rate.
Okay, so as I said, the recurrence after open TAR in published literature is in the ballpark of 4%. And in most of these studies have come from Cleveland. And those cases have happened because of central rupture of polyester mesh. Subsequently, that gigantic polyester mesh called Versatex has been withdrawn from the market, and Uri and others do not use polyester anymore. So polypropylene is what is used. So mesh rupture has come down significantly. So we would expect that in the coming years, we would see very low recurrence rates after TAR, because without a mesh rupture, the incidence of TAR is less. And if there is a recurrence after TAR, it's usually your fault because you've not done adequate dissection, cephalad, or inferiorly or laterally, or your mesh is too short.
There's a question by Dr. I.N. Mohanty, Assistant Professor Surgery. Can we do this procedure in case of big parastromal hernia?
Yes, but don't try it the first TAR that you do. It's a separate learning curve to do a PPHR, which is called the polyparastromal hernia repair, which has a TAR component to it. It is a difficult operation, needs experience and training. So yes, definitely you can do it.
A question which I also wanted to ask from Dr. Sandeep Reddy, management of intra-op damage to the neurovascular bundle, if I incise it accidentally.
Well, there's nothing you can do really. Just pray and waive off your charges.
Dr. Rajkiran from Manipal Hospital, role of eTEP in current scenario for ventral hernia.
Well, you know that many of us love eTEP in the AWR Surgeons Community as well as in the IHC. The eTEP does everything that a TAR does without that big cut. So I would say it's a fantastic and versatile approach to all sorts of hernias, from inguinal to xiphoid and even flank hernias. And it's a very, very evolving field, developing field. The patients do very well. Surgery is difficult. It has a steep learning curve, but the patients seem to do very well. And our results, which is accumulating by the day, is very encouraging. We are delighted to do eTEP for all sorts of hernias.
A repeat question by Dr. Sandeep Reddy. How to manage if the patient develops peritonitis who underwent TAR? Peritonitis may be early or late.
Missed enterotomy. Patient's going to die unless you really do something drastic and do it soon. Don't sit on these patients. If the patient's not doing well, quickly take the patient back to theater. Okay, you'll do your blood count, you'll do your procal, you do your lactic acid levels and all that, CT scans and all that. But when needed, if you're still not happy, don't wait too long. Take the patient back to the theater. Patients can die.
Dr. Shiv Kumar from Apollo Hospital, Vellore. How long will you keep the drain?
I don't drain. Exceptionally, I do. If at all, don't keep it more than 7 days. Most people don't.
And if
Even if it is draining, remove it on 7 days.
If the drain is not draining, what will you do?
Remove it.
Okay. What other abdominal surgeries can be combined with AWR?
No standard recommendations can be made as to this point. Teaching point should be don't combine gallbladder with TAR, hysterectomy with TAR, appendectomy with TAR, hiatus hernia repair with TAR. Try not to do too many things.
Dr. Ramanuj from Baroda wants to ask, what about cranial fixation of mesh and TAR? There's a lot of question about fixation.
Right. So use a suture passer and go above the xiphoid, on side of the xiphoid, wherever it is safe, and take a suture through the upper part of the mesh, not through the edge, just maybe a couple of centimeters below or 3 centimeters below the upper end of the mesh, and then pull it up. So what happens is, wherever your fixation point that is close to the xiphoid, the mesh edge will go another 3 centimeters above. So that is how you could take a cranial stitch to fix it.
Dr. Hiren Vaidya from Surat, he's asking how to manage divarication of recti.
Isolated diastasis, you may choose not to do anything. I would typically operate on diastasis when it is associated with a hernia, or if the patient is very concerned about it and I'm doing a bariatric surgery at that time in an obese patient, I might just do a suture repair. That's a different story. But diastasis is very well repaired with a small umbilical hernia by the subcutaneous onlay laparoscopic approach, the SCOLA or REPA operation. And I like that operation. It stays in a nice clean plane and does not violate the retromuscular space, which you can reserve for a more serious occasion. Otherwise, I wouldn't want to go into an eTEP space for a diastasis.
Sir, are you open to taking some more questions?
I'm fine. Okay, I'm fine.
Dr. Arijit from AIMS Raipur is asking that wouldn't the mesh impair the normal physiological abdominal movements? The mesh is a big in size.
The negative impact of mesh, I think, is vastly overrated. There is a school in the public and media in the Western world which creates panic out of the side effects of meshes, and many people make their living off such scare stories, scaremongering. I think in the vast majority of patients, overwhelming majority of patients, mesh provides immense benefit and long-term cure from hernias. Now, if you go back to suture repairs, you will realize what a humongous number of these patients will come back with recurrences and how useful meshes can be. After AWR, the abdominal muscular function, the core function as we call it, has been tested in, I think, 2 Cleveland studies. And by dynamometry, they have found that the core function improves after AWR. So there is no evidence or substance to this allegation or fear that doing AWR is going to weaken the core, weaken the muscles, and putting in a mesh is going to create more problems. I think that's vastly overstated. It's kind of like the vaccine scare, which is now affecting and infecting the Western world.
Dr. R.K. Verma from SMI Hospital, Dehradun, is asking if there is a repeat surgery which needs to be performed after TAR, what are the various things which you need to keep in mind?
Right. First choice for me would be an IPOM. So after a TAR, I would probably be looking at an isolated punched out defect at one edge of the mesh, or maybe it could be a central mesh fracture and could be central. So I would go and do an IPOM there. Alternatively, you could do an open onlay.
Dr. Shrikant Patro from Cuttack. If somebody has a symptomatic gallbladder stone and there's a huge incisional hernia, what to do? What is the management?
I would look at the gallbladder stone first, do the lap chole, and anytime after that, when the patient is willing, take care of the hernia.
Dr. Rajkiran from Manipal Hospital, Bangalore. Percentage of linea alba dehiscence in your practice and in literature?
Linea alba dehiscence means recurrence. You mean linea semilunaris dehiscence? I don't know what the question exactly is. But I think in my eTEP practice, you're not talking about open surgery, because in open surgery, you're opening the linea alba anyways. In eTEP, you're supposed to safeguard the linea alba. I think I have done it a couple of times in over 200 cases.
Dr. Professor Arvind Patil, what if there is an infected mesh sinus formation? What do you do? Whether you remove this or not? When do you remove it?
So I would basically treat the sinus separately. I would just remove the infected mesh or suture, curate the sinus or lay it open and treat appropriately. Does it need specific antimicrobial treatment like for atypical mycobacteria? And I would not do a hernia surgery at the same time, AWR at the same time. Why not? Not because there is anything evil in doing so. It's because we do not have in India those meshes which can be safely used in this kind of scenario. At the most, I could say you can use a macroporous lightweight polypropylene mesh. So I would kind of discuss this with my patient. I would say that I typically do not do this, but there is evidence that you can do it with a greater chance of wound infections, which does it sound better. So if the patient says, okay, why don't we try, then I would go ahead and do the AWR. But in India, I would say that atypical mycobacteria being a notorious issue, we should not be looking to put in a mesh unless we are sure that we've taken care of that problem.
Professor Puranik from AIMS Jodhpur is asking, can you tell us how many patients require ventilatory support in your experience, and if there is any difference in the outcome in those patients?
A very good question. Every loss of domain patient should be counseled and prepared for ventilatory support, elective ventilatory support. You may not need it, but it's always a good idea to have elective ventilatory support for at least 24 hours or overnight, especially if you're finishing a long surgery and the patient is frail and critical, not optimal, whatever it is. I would say it's always a good idea to keep the patient electively ventilated for at least 24 hours. And people have had to do it for much longer, even a week. So only the loss of domain patients would go on a vent, not a routine complex ventral hernia. Only when there is a substantial loss of domain, not otherwise.
Dr. Iqbal Singh from Fortis Mohali, is base plate mesh necessary over diameter place 30 by 30 mesh?
If your patient is very short, Indian woman 5'2" or 4'11", complex hernia, then you will get away by putting in a 13-30 diamond shape, like I did in that unilateral TAR case. But if the patient is a male or a taller female, one mesh is not going to be enough. You're going to have recurrence. You've created a large space, protect that entire space using 2 meshes. You can tailor that second mesh, but do that home plate formation. Quilting of the mesh, do it.
There's a lot of demand for your nuggets of wisdom. So there is a question from AIMS Jodhpur. Your 10 points of wisdom and technique for this starting.
Oh my God. I spent 1 hour pouring my heart out into this presentation.
Like 10 testaments from Dr. Ramana.
Oh, well, I don't think I'm in that league to give you 10 commandments like Felix. But I would say I've been saying this repeatedly. Don't jump on the TAR bandwagon. So train properly. Take your time learning it. I have had people attending my workshops and conferences for 2 years before they have taken up a case independently. That is dedication. I'm not saying everybody needs to do it, but that's the kind of mindset I'm talking about, that you take your time and learn that procedure without making all the mistakes that idiots before you have, right? So I would say, number 1, training is paramount. Take your time. Number 2, select your patient properly. Don't pick up an obese smoker or a patient with heart disease or compromised liver function. So pick your patient up properly. Prepare your patient. Take your time in preparing the patient, whether it is obesity management or diabetes management or whatever. We've discussed that. Number 4 is prepare for your operation. I gave you a small checklist of all the things you need for surgery. So make sure that everything is ready in advance, including all the meshes that you want. Think of an escape route if you get into problem. If you have bowel resection needed, do you have staplers? Do you have those sutures? Do you have all the meshes available, including a vicryl mesh? That kind of thing. Next, make sure that you complete your adhesiolysis without injuring bowel. I told you, this is for me, the number 1 goal of surgery is to avoid injuring bowel. Number 6 is do the retrorectus dissection patiently, identifying every fiber where it belongs, and do not injure the linea semilunaris, the neurovascular bundles. I keep saying this, the neurovascular bundle should be considered as the CBD of the abdominal wall. Do not do a CBD injury. Then I will say that excessive traction during dissection is bad. It tears the tissue and will take you to the wrong space. Ninth point, I would say, is reclaim your lost planes. If you lose your plane, don't get disheartened. Try to find muscle above you. You should not be finding muscle below you. If you see muscle below you, you are in the wrong plane. All the muscles should be above you after you do the TAR. So number 9 is reclaim your lost plane. And number 10 is close patiently, putting the biggest possible mesh in that space. So let's just keep it to point number 10 is put the biggest possible mesh in that patient. There, I got 10 points.
Yeah, that's great, sir. Question from Dr. Roshan, that's me. Polypropylene mesh has a high shrinkage rate. So do you feel there is an advantage of tie mesh over polypropylene mesh, especially in large repairs?
Possibly. The mesh shrinkage rates have been kind of all over the place. Initial rates were like 50%. Does the mesh shrink more in the sublay space? Probably yes. So we have newer and newer materials coming up every year. So there is tie mesh, there is a PVDF mesh, which is popular in Europe. We don't see much of it in India. So the shrinkage rate of these meshes is lower than polypropylene, and heavier polypropylene is going to shrink more. So definitely these are issues which we are going to have to deal with. We don't know enough to take a definitive stand on it, but yes, interesting to debate and discuss.
There's a question from BLD Medical College, Bijapur. What is the maximum width which can be kind of repaired by the TAR procedure?
20 centimeters, 22 centimeters, I think would be pretty big defects. But people in Cleveland and New York may do cases which have 25 to 30 centimeters as well. So they do really big ones because their patients are also very big. We also have big ones. That's true.
So there's a question by Dr. Shrikant Patra, SCB Medical College. If tie mesh is adhesion retardant to the intestine, then can it provide and develop enough fibrosis for better support?
Excellent question. I think yes. No definitive answer. Early evidence, preliminary evidence seems to be that yes, it can give adhesions to the fascia, and it does its job fairly well. But I'm not saying that this is the last word in this.
A question from the same doctor. If I want to start minimal access way, then which one should be the first approach? A lap TAR or eTEP TAR?
Absolutely eTEP. Absolutely eTEP. Start with a single large inguinal hernia, do the eTEP access, or take bilateral inguinal hernias, do eTEP, or a sliding hernia, phalansteal hernia, do these eTEP. And then take a small umbilical or an epigastric hernia and do a few of those. And then as you get more comfortable in the space, go on and become more adventurous. But definitely don't jump right away. There's a very steep learning curve for eTEP.
So I think there's one more question coming, sir. Maybe you can put your concluding remarks and then I'm just waiting.
All right. So the thing I would like to say is that we are really scaling up the AWR subject in India and surrounding countries and making it more accessible, more easy to learn, safer to learn for any surgeon who wants to do it. I'm not saying everyone needs to do it, but if you are keen to get onto the AWR space, then you have to be dedicated. You have to have that mindset. You can't be a man in a hurry. It's not your lap chole. You can't just finish it off quickly and move on to the next case. You must double down on each case and each procedure. We are going to have a spectacular event next year in Mumbai, IHC 2020. It's the Hernia Olympiad. You don't want to miss it. We will have the mega stars of the hernia world coming there, doing live surgery, cadaveric labs, everything that you can think of and more, we will have it for you. That's a promise. It will be an experience you will never forget. So block your dates, May 28th to 30th, Mumbai, and feel free to ask me any question. I'm very easily traceable. You can check me out on Facebook or Google or whatever it is.
So there's a concluding question. This question you already answered, but the doctor was not on the call. Dr. R.K. Verma from SMI Hospital, Dehradun. What is, if there is a TAR, a patient has already undergone TAR, what happens if there's a recurrence?
Post-TAR recurrence is usually subxiphoid, or in the center, it could have happened because the mesh is ruptured. I would do an IPOM. So put in a scope, take down adhesions, see the defect, and then put across a coated mesh. So that's about it. Yes.
So, on behalf of LDM, I'd like to deeply thank Dr. Ramana for sparing his valuable time, more than 2 hours, I would say, and delivering a very powerful talk. I'm sure with the quality of questions coming in, I'm sure Doctor must have understood how the indulgence was from the audience. On behalf of the corporate, I also want to thank all the doctors from across the world for taking your time, participating in this event, exchanging thoughts with Dr. Ramana. I am sure it was a great learning experience. I also want to thank my colleagues, Dr. Roshan, Chandu, and the entire staff of Dr. Ramana's clinic, and my colleagues from the sales team, and everybody in the field. And I would request Dr. Ramana to give his final few words, and then we close the session.
Thank you very much. Have a nice evening and a great weekend.
Thank you very much. Thanks for joining us.
Thank you, sir.